All right, good afternoon, everyone. This is session IC48. We have importance of standing on early development, and today Maryann Girardi will be presenting to you guys. So enjoy the presentation, and we'll give you the CEU code at the end.
Thank you so much. I apologize, my voice is coming and going, and hopefully for the next hour it will come and not go. She said, my name is Maryann Girardi. I'm a physical therapist. I've been practicing for over 40 years. And during my time, I've split my time between pediatrics, usually children with multiple disabilities, and adults in seating clinics. And it was funny, I was talking to somebody yesterday, remembering the first ISS I went to 30-something years ago in Memphis, and how different it is and how much it's changed and what we see. And it was like, when I got there, I thought I found Mecca. I was like, people who thought out of the box and were willing to try just about anything to get what they needed. So 30-something years later, I'm still coming back. And today I'm going to talk to you about the importance of standing on early development. And let's get this working. I'm not going to do it. All right, I do have a disclosure. I am a full-time employee of Ultimate Medical, who are the manufacturers of Easy Stand and Zing standers. I am not a researcher. I'm a physical therapist and practicing therapist, and I've pretty much done all my practice in the state of Massachusetts. So today our learning objectives are going to be describe how supported standing facilitates skeletal development, discuss how supported standing can be used to assist in the development of postural control, and discuss how supported standing can facilitate the development of motor skills. I think everyone in this room knows that there is evidence for the use of supported standing. It's not high evidence, it's not high level, and there's not a lot of it. And Jimmy mentioned it this morning that if you are doing and having successes and write up case studies, it can help us justify it and help us get more evidence. And if you want to send them to me, I'd love it. I'm trying to compile a library of case studies. So first, we're going to talk about skeletal development. And mechanical loading is necessary for healthy bone development. Loading from muscle action and from weight bearing stimulates bone growth. Within the bones are the mechanical receptors, which stimulate the production of new bone cells. It also inhibits the release of the protein sclerotocin, whose only job is to inhibit bone growth. Nutrition, hormones, and medication also affect bone growth. We all know that people who usually have either brittle bones or decreased bone mineral density, they will usually find that there's a vitamin D deficiency. So it's important to increase vitamin D. The medications we all know, the anti-seizure meds, the kids who take the anti-seizure meds from they're young, it saps their bone mineral density, does awful things to them. When we're talking about changes in bone, we need to talk about Wolff's Law. For those of you who aren't familiar with Wolff's Law, it's from the 1800s, and it basically says that any force on a bone will change the structure of the bone, in other words, the density and its strength, but it also changes the architecture and the shape. So what happens when children are not weight bearing, I've heard it referred to as we end up with children who have a skeletal system that's unable to withstand daily life. I think that might be an extreme. But we do find that 97% of the children with cerebral palsy who did not walk after the age of 9 have osteopenia. 65% of the spina bifida kids have decreased bone mineral density. And because we're talking more about younger children, I'm not going to talk so much about your Duchenne's kids, but we all know the Duchenne's muscular dystrophy boys have severe bone mineral density problems, but they have a double-edged sword. If you're using medications such as corticosteroids, that's going to sap the bone mineral density. And the reason we're concerned about increased bone mineral density or adequate bone mineral density is because they find with decreased bone mineral density, you're at an increased risk of fractures. The value that I've seen is 1 gram per centimeter squared for bone mineral density. After that, you're at severe risk for fractures. There was a study done a while ago which compared typically developing children and children with cerebral palsy and their fracture rate. They found that the frequency of fractures was not different. What was different was the trauma, what was happening. Your typically developing children were fracturing, sliding into home base, falling off the jungle gym. You can tell my age. I don't even know, do they have jungle gyms anymore? I think they were outlawed in my town. And the children with cerebral palsy were fracturing, getting dressed, being transferred from wheelchair to wheelchair. And my favorite one has always been when the foot turned out and they went through the doorway and you got a spiral fracture of the tib fib. We need to have strong bone mineral density in these children so that they can withstand the pressures of everyday life. Bone mineral density is a checking account. Think of it as a checking account. All through your life and through your growing years, you are putting deposits into that checking account. You put more deposits when you're in your periods of rapid growth. So your early childhood years, your early development years, early childhood, adolescence, and young adulthood. The sad thing about bone mineral density is there comes a time when you're going to stop putting in deposits. And that happens to everybody around 40. And at that point, the body starts reabsorbing. So when you're talking about standing for the older people or for your spinal cord or paraplegics, you're not so much talking about building bone mineral density as decreasing reabsorption and maintaining what mineral density they have. What happens with our adults with CP or older children with CP is they never. There's a puppy over there. Oh, okay. I thought it was my dog. I thought Apollo was here. Thank you for clarifying that. Doesn't it sound like a dog? So you're building up your bone mineral density at your younger years, your periods of rapid growth in your early adulthood, and you get to adulthood. But what happens with children with cerebral palsy and children who weren't active and up and mobile when they were younger is that they didn't make those deposits. And when it comes to their older age of 40, when everyone starts losing bone mineral density, they don't have enough and they're going to become overdrawn. And when they become overdrawn, they're going to fracture. When using standing for bone mineral density, I like this study. And again, the evidence for bone mineral density is fairly high, but it's not high quality, most of it. I like this study because it also looked at the growth and the length of the bones, because you find that children with cerebral palsy are usually about 2 inches shorter than their typically developing counterparts. In this study, they had 2 groups, one standard with exercise and assisted standing for 2 hours a day, 5+ days a week. The second group had the conventional therapy and only stood 20 minutes a day, 2 to 3 days per week. What we found was there was an increased trend in bone mineral density in the first group, who stood 2+ hours a day, 5+ days a week, and a decreased trend in the group that only stood 20 minutes a day, 20 to 30 minutes, 2 to 3 days a week. I think we've all seen the data that shows that bone mineral density is time and frequency dependent. Because if you think you stand for 20 minutes a day, once a week, you're going to maintain your bone mineral density, you're not. You're not going to build it as a child either. What they also did was they studied the bone, the length of the bone, and they found that the control group, so the control group was your typically developing children, their increase in length was 39%. The group that stood for 2+ hours a day, 5+ days a week, the increase in growth was 30%. So just about a 9% different. The ones who only stood 20 minutes a day, 2 to 3 days a week, only had a 20% increase in growth. So by not standing the full time, the multiple days, you're cutting your bone growth in half when compared to typically developing children. We've seen them all for bone mineral density. This one, they stood an average of 30 minutes a day from 4 to 18, and they were able to have an increased trend with the standing group maintained it, and the non-standing group had a higher reabsorption. I want to go run for my dog. Also in skeletal development is the normal pelvic development. If you can see in the pelvis, when you're born at 9 months old, you don't really have a femur. You don't really have an acetabulum. There are growth plates there, and the osteoblasts in the growth plates stimulate more growth. Weight bearing increases that. By 11 a month, they're starting. But if you also notice, the femur is starting to change. And by 2 years, you've got a head of a femur. It's still not fully grown yet because you're not fully done growing, but you've got an increase in the head shaft angle. It's a closer look at the head shaft angle because there's two schools of thought when it comes to hip dysplasia. One is that head shaft angle does predict. So if you have a head shaft angle greater than 174 at 4 years of age, you're predicted to have a hip dislocation. The other one is saying now that it has no bearing. But I think it's important to see, and from my own personal experience, when I worked with children, I'm trying to think, he was 9 years old, and I had that wonderful abduction brace, the big red one that you had to try to get on him. Oh, did I mention he was deaf and blind on top of cerebral palsy and trying to explain why I was strapping him? But I saw his x-rays for the first time. He had never weight bared in his whole life. He was 9 years old. His femurs were totally straight. His hips were popping out. There was nothing to hold him in. And he hadn't had the greatest orthopedic care before I saw him. So with hip dysplasia, they say the difference of the hip dysplasia I'm talking about is not congenital hip dysplasia. The children are born with normal hips, and the migration, lateral migration, hip dysplasia, neuromuscular hip disease, hip dysplasia, and cerebral palsy. There's a couple other names it goes by. It's all the same thing. What happens is over time, either because a combination of the lack of weight bearing and an imbalance of the muscles, the head of the femur slowly migrates laterally from the pelvis, going towards subluxation and dislocation. And it's not just a spastic disease. It also happens with children with low tongue, and they still haven't quite, they can't say, well, if you do A, B, C, and D, this is going to cause it, or if you do A, B, C, and D, this is going to stop it. So that's what hip dysplasia looks like. The normal hip all the way to your left, subluxed on the right, which is anything greater than a migration percentage of 33%, and dislocated, which is a migration percentage over 40%. Once the migration percentage gets to 40 or 50%, it will progress to dislocation quickly. What's the migration percentage? There are multiple ways to measure hip dysplasia and to think about it and to diagnose it. When I was in school, back when we used, a stone and chisel, we were told if you can't abduct the hip, they're in trouble. Well, they found that hip range of motion is not really that, and it's indicative, but it's not that the gold standard to determine. What it is, it would be Reamer's migration percentage, which is done on an anterior, posterior, or front to back x-ray of the pelvis in a specific position. They did a study on the x-rays and the results of x-rays across the country, and they found that every x-ray tech put the person down in a different position. And what happened when they put them in different positions, they got different measurements. So they have to have a neutral pelvis, they have to have their legs in neutral, and they take the x-ray, and what they're going to do is draw lines from that lateral border of the acetabulum to the lateral border of the head of the femur, and they're going to take that space in between, multiply that times 100, and that's your migration percentage. And when you're talking about hip dysplasia, you're going to hear it referred to as the migration percentage or the MP. And remember, we said earlier that if it's above 33%, we're going to get worried. So they found that children who stand with abduction for an hour a day, starting at age 12 to 14 months to age 5 years, they were able to control the migration percentage. Those who did the standing remained stable at 13 to 23%, where the treatment group who didn't stand progressed to 12 to 47%. It's not a cure for hip abduction. or hip dysplasia, but it can help. The other group, what I like about this one is that they compared standing in 30 to 60 degrees of total abduction for 10 hours a week to 10 to 20 degrees of abduction. We've heard a lot talk about standing in neutral and the hips coming out. And I read a few articles that said that standing shells do not help, but if I looked at the pictures, they were all standing in neutral. So there wasn't any abduction. So when the children stood at 30 to 60 degrees of abduction for the 10 hours a week, they were able to decrease their MP by 7%, where the ones in the control group who only stood at 0 to 20 degrees were able to increase their MP by 6.5%. When you're looking at degrees of abduction that you want to put a child in, you're never going to go past what's comfortable. So when you get a very small child, you're not putting them up to 30. The first time you put someone into a stander, I would not put them in to 30 degrees of individual leg abduction. For the therapist, when you're putting someone into a stander, you need to look at the ASIS. You need to look at the pelvis, because you need to make sure as you're coming out into abduction, it stays level. We want everything in alignment. We go back, we're part of, the 24-hour posture care management and preventing deformities. If we do not allow children to be in asymmetrical postures for prolonged periods of time, we can reduce the development of deformities. And those deformities not only are scoliosis, hip dislocation, knee flexion, wing blown. If we can keep people in alignment, we can keep the muscles flexible and prevent, because if we're out of alignment for a long period of time, our friend Wolf comes back. So we've got our bone out of alignment, and he's going to change the architecture of the bone because we're not using it the way it needs to be. So he's going to change it to make it effective the way it is being used. The other thing that I always remind people to check and check myself is when you're moving into abduction, make sure you have good alignment from the hip all the way to the foot. Again, Wolf's going to come. If you've got a bend there somewhere, if you've got some external rotation, the body's going to adapt. It's not just the bones, the muscles are going to adapt. So you want to make sure if you're using the stander and you're putting someone in a stander, everything's in alignment. If you can, there's a leg length, you're not going to be able to have it. The foot plate's going to be different. Going to have it in alignment. You're going to have the pelvis level all the way down. So the theories behind abduction, we heard this morning that it's not always true, that if even when you're in 20 degrees, you can come out, but the theory is physics. I don't know about you PTs out there, but I hated physics. I went to a tech school and I had to go over to their campus to take physics. What physics does, you got the head of the femur, I'm going to hit this mic, get the acetabulum. And abduction takes and moves the forces from the head of the femur immediately into the acetabulum. The thought that I've read is that if it stays lateral, Wolf is back again, he's going to flatten out the head of the acetabulum. You also need, for the bones to develop and shape, you need to have the acetabulum and the femur together in conjunction, so the acetabulum can form around the femur, the femoral head can become round, and the head shaft angle can decrease. By decreasing the head shaft angle, what am I doing to the head of the femur? I'm putting it into the middle of the acetabulum. What do they do in derotation osteotomy? For those of you who don't know what it is, they cut the shaft of the femur, realign the head, and put it together. Guided growth does the same thing. Guided growth is where they put a screw through the head of the femur to guide the growth of the acetabulum so that it's at a good angle, the femur, so it's a good angle with the acetabulum. So as far as skeletal, standing can help to reduce the progression of the MP. It can help to reduce the MP in certain cases. As we know, nothing's absolute. We can facilitate the development of the hip bone joint so that we have a good shaped acetabulum, we have a proper alignment with the head of the femur. It doesn't guarantee there's not going to be surgery. we all know nothing's 100% guaranteed, and there can be times. But even having surgery doesn't guarantee there's not going to be another surgery. There are sometimes things going on in the skeleton and the muscular system that just cannot be corrected and need to be corrected over and over again. Another common impairment that we treat with standing is lower limb range of motion. They did a study. Is anybody familiar with CPUP? CPUP is the cerebral palsy follow-up program in Sweden. It's been around since 1994. They have all this longitudinal data on CP. So they went back and looked, and they found that lower extremity range of motion consistently decreases in children with cerebral palsy starting at the age of 2. So if your child isn't getting therapy or going into services in the older, before early intervention, until they were 4 or 6, or until they had the official diagnosis of cerebral palsy, they could already be starting the contractures. They found that muscle growth, skeletal growth, and muscle excursions stimulate the muscle growth. As we move, the body is going to accommodate to what we need. If we move our arms through the full range of motion, the muscles are going to accommodate. If we hold it in a position, it's going to accommodate. It's going to shorten so that it maintains the mechanical advantage for the range of motion you're using. They find that weakness, so if you have opposing muscles where one is stronger than the other, or there's spasticity in the weakness, you will develop a contracture in that area because you can't go through the full range. They found that 5% of knee flexion contraction greater or equal to 5% is common in children with cerebral palsy. Think of it, they find you tend to get the crouch gait, then you get the ankles. And if you're not doing anything, and we all know, those of us who are therapists know, passive stretching doesn't work. And I feel so guilty because I had my parents stretching their kids 30 minutes a day, every day, and they kept losing range. I didn't know any better. I do now. They find that if you use standing in abduction, this was the same study from before, that they stood for 70, 90 minutes a day and only 35 days on the weekends, they were able to maintain the hip range of motion and kept it for 7 years. The reason it ends at 7 years is that's when the study ends. So what does hip range of motion do for you? You can change clothing. You can do hygiene. You can sit in a chair. You can walk. You can be comfortable when you're in bed. Range of motion is more, I think, when you get to the older population, it's important to the person because they are not in discomfort when they're getting their daily hygiene, but it's a lot more important to the person who is doing the daily hygiene. And it prevents secondary complications of skin breakdown, infections. I think this study has been done over and over, everywhere in the country. A friend of mine did it back in the 80s in Boston. When you put someone in a stander and they use their stander and they use it consistently, they can improve lower extremity range of motion. When you stop, and in my friend's case, she sent the kids home for school vacation. They stopped standing, they came back, they lost their range of motion. The thing about standing is that you have to keep it going. When you stop, you lose the benefits of it. I'm going to take a little walk down motor development. Keep hearing noise. So motor development is the development of a child's bones, muscles, and ability to move around and manipulate in his or her environment. When we think of it, most of us think of the developmental milestones. It's a building block as you go up. It is a group effort between the individual. So the individual, not only who the person is, but what are their impairments? What is their body makeup? The environment, where are they being raised? Where are they expecting to be? Where are they experiencing life? And the task at hand. What are you trying to do? I use Gallagher's theory of motor development, which is a progression. You start with primitive reflexes, which you gain information about the body. They're totally involuntary. You have no control over them, but you gain information about your body and environment. Then you have your postural reflexes, which he refers to them as testing the neural units of the body. You've got your reflexes, they're trying to get the body to move and move within space, and they look more like later voluntary behaviors. Then you've got your rudimentary phase, which is when you're beginning to use your more voluntary movement. You're able to make small movements. They're not great, you're not skilled, but you're doing it. And then the fundamental phase is when you can have observable patterns and you can adapt to any environment. In his diagram, it's a reverse hourglass, but you notice in the bottom, you've got the contributing factors within the individual, which could be any impairments. You've got the constraining factors in the environment. If you're not getting stimulated, if you're not experiencing your environment, that's going to affect your motor development. You also get the constraining factors in the task. If the task doesn't have any meaning to you, you're not going to do it. And then at the top, there's heredity and environment sprinkled in together. And you move through these till you get to motor control and components. Postural development is you have to have posture. If you don't have sitting posture, or standing posture, or the ability to hold your trunk up, you're not going to be able to move through your environment. You're also not going to be able to move and reach for things. It's a complex interaction of sensory and musculoskeletal systems that maintain the body's upright stability and orientation in space. It's how you stay where you are. When you're developing posture, they found that you start to initiate the next level before you can master the level before. So you initiate standing before you can master sitting balance and sitting postural control. Learning is a change in the capability of a person to perform a skill that must be inferred from a relatively permanent improvement in performance as a result of practice of experience. We need to learn through experiences. We need to learn through practice. We don't always succeed the first time, and sometimes we're so far off it's not even funny. It's really embarrassing when you bowl for the first time and the ball goes down the next alley. Don't recommend it. But we have to have that experience. You have to know what failure means. Even if you're trying and moving and you fail, you learn from that. And our children with motor impairments don't get that experience. They're not able to move, or they can't change their position, and we need to provide them with environments for them to learn. I'm going to talk very, very, very high level about motor learning. We're going to talk about Gentile's two-stage model and Bernstein's three-stage model. With Gentile's two-stage model, the initial stage, you're acquiring a movement pattern that will allow some degree of success at achieving an action goal of the skill. So you're learning how to move. You're developing motor patterns. You're trying and erroring until you find something that works and you refine them. Along this process, you also have to realize what's in the environment that actually has an effect on what you're doing and doesn't have an effect. They're called regulatory and non-regulatory. So if the skill and the task that you want to do has to be within a box, then the box is regulatory. If the skill of the task is in a room, then the walls of the room don't matter because you're not going to be anywhere near it. You need to be able to determine between the two of these and adjust your motor pattern accordingly and experience success. If you don't experience success in accomplishing the task, even with assistance, you're never going to know what the task is. The second stage is the ability to adapt movement to changes in task or environment. So basically, you've learned the movement, you've learned to take away what's regulatory, what's non-regulatory, and now you're able to change when things change in your environment. You don't have to bowl in that same lane every time you go. You can bowl in another bowling alley. You can use it. Do you guys know what candle pins are? Okay, I thought it was only a New England thing. You can do a 10-pin, you can do a candle pin. Are you going to change? Yes, you're going to have to, because that 10-pin ball is heavy. So the motor learning will have to have some adjustments, but because you're the ability to adapt with the task and the environment, you're able to do it. Bernstein's 3-stage model. When I think of standing, I think of this mostly when I think of a stander. The emphasis is on controlling degrees. What Bernstein found was that when people go to learn a skill, when they go to learn a new movement, they voluntarily or their body locks out joints. So they're not trying to control the whole joint to get through. And then as they gain skill and they learn it, they go to the next joint. They loosen up the degrees of freedom and make it easier for them to move, to learn to control the whole body. When you're at the expert stage, you can control all degrees of freedom. You don't need any help as far as controlling joints or locking joints to enable you to do the task. You can control all degrees and make the adjustments needed. I'm borrowing this from my OT friends. Backwards chaining. I'm putting this in because I personally have had a lot of success with it. And it goes along with the idea that you start out with a completed task. Backwards chaining in OT is usually used for dressing as one of the skills. I've used it to teach balance to children who didn't have vestibular systems, who didn't have vision. We were able to use the backwards chaining effect that we could take and provide them with the experience and the feeling of being successful at riding a razor scooter. I get looks. When I brought the razor scooters into the school, they're like, they can't walk. I'm like, get in here. You can provide all the support you need. And when we started with these little kids, we had 2 people on one so that they could maintain and move through space. As they got confident and they learned the movement and they could feel it and they could experience it, we backed off the support to the point where some of the more successful ones were able to ride them in the hallways. We didn't allow them in the playground. But backwards chaining, I think, is really successful for any type of skill. You need to know what you want the final task to be and what it's supposed to look like. What happens with children with neuromuscular is we're talking about degrees of freedom and postural control and how standing can help, is that they're trying to stand. They don't have a mature sensory system. They don't know. You have to learn what senses are. You can feel them, but you don't know what they are. You have to experience them and learn them, with the exception, I think, of pain. They can't control all their joints. It's like a house of cards. You're trying to get, or this little guy, you're trying to hold him and too many things are moving, you can't control it. And especially children with cerebral palsy, they don't have the muscle control. They use more of the reflexive movement, which is quick and fast and has a lot of torque. And then they're just constantly moving and then they're exhausted and they just fall asleep, which in some cases isn't a bad thing. So what standing can help is you can provide the external support necessary to get a finished product. So when you're working with the idea of backwards chaining or Bernstein's theories, you provide them all the support to control the degrees of freedom. You let them know what the finished product is going to be. You enable them to feel the sensation and the proprioception of the ground coming up through them. You increase their visual fields because, let's face it, if you're down crawling, you get to see the hardwood. If you don't have enough neck extension, all you're going to see is the hardwood. You're not going to experience. When you're up in a stander, you can have more sense of freedom. You can look. if you're working with a child in a prone stander, and I like prone standers because you can get good co-contraction, get closed chains, you can work on neck control. Problem is if you've got a child with a visual impairment, make sure they can still see. Make sure they can see their environment, because if they have a superior field cut, you just cut out their whole world. And all they're going to see is what's on the tray. So always keep that in mind. If you've got them upright, we heard for those who are in the targeted training, the SATCO course, you can provide the support and only work on the distal and work it back. And as they gain control in the postural, in the spinal column and postural control of the trunk, you work it back and give them the experiences, but you're also providing them the feedback to be successful and learn what it feels like. We develop from head to toe. And we give them a safe environment. There's nothing worse when you're trying to get somebody who's never had control of their movement up against gravity. And if they've never experienced gravity, they get scared. And then you get fight or flight coming in, and you're not going to get anything done. When you're doing things like this, of course, you need to have something to create their attention and a task or something that's going to give them direction for why they're standing there. I hate talking to, it's more with the adult population. So what do you do when you're in your stander? I stand. I watch TV. Or my other favorite one, I look on my phone. Great. Remember we said if you stayed in asymmetrical postures long enough, you're going to develop postural deviations. We can also use it with motor skills, and it's not concrete evidence. It's not even, but what they've seen is they use children standards. This child was 18 months old, had no intervention at all. They were in a standing program for 5 days a week for 12 months. And at the end, they increased their gross motor functional scale. They also increase their ability with head control, upper extremity function, and increased sitting ability. I'm not a researcher. Never been a researcher. That was the worst class I ever had. But I can see when other people have had good success, and I'm willing to try it. I've always considered myself a cocktail therapist, which is you take a little of this, a little of that, you put it in the shaker and shake it. If it works, you keep going. If it doesn't work, you throw it out and find something else. I think we need to continue to explore what we can give these children. And now that we have early intervention and we have the ability to have a diagnosis of CP or at high risk of CP at 5 months corrected age. Early intervention has proven that if you can get in and provide services earlier, you get better results. And maybe we won't see people with the severe deformities or the contractures or the decreased muscle skills and motor skills that my cousin has. She lived in a crib for her first 5 years. Nobody knew. We didn't know you had to change her. We didn't know you had to, get her out of the crib. We can find that we are seeing case studies and individual studies where children are being used in standards, and the parents are always saying, wow, their head control's better. They sit better by standing. It's the same idea. If you lie better, you can sit better. You need to have control of your body and the range of motion and the skeletal form to be able to carry it through the different positions. They also found that children with myelomeningocele who had 2 hours a day for 8 weeks, they had an improvement on 2 points in the trunk impairment scale, and they had a 1 point improvement in the GMF88. There was no change in the PD, but they did find that they were able to sustain positions better. They were able to hold themselves upright. I worked with another young woman with spinal bifida through consulting. She was a teenager, got into a stander. She was still walking, severe hip and knee flexions, got into a stander, was able to get 85% correction in her lower extremity range of motion. Her gait got better. She wasn't using as much energy to get from point A to point B. She was standing taller. She was 16. I'm not going to stand in a stander. I can make my own mind up. She stopped and she lost her range of motions. This is the American Academy of Cerebral Palsy and Developmental Medicine hypotonia pathway. They suggest starting with adaptive equipment, gait trainers, and standers at 9 months to provide these children with the experiences that we've been talking about. I wasn't able to find a study, but anecdotally, I've been talking with a therapist in South Dakota, Sioux Falls, South Dakota, right? And she's been using it with her early intervention Down syndrome children for years. And she finds that they are up and standing, they're walking quicker. She actually, when I was there, when we were together in wherever it was, Minneapolis, I think, she had just gotten an email from a mother who they had started a little 3-year-old girl standing in his supine stander just a few weeks earlier. And the mother texted her to tell her that she took her up and stood her and she actually bore weight for a second. So it can make changes. Standing also has other benefits besides motor and skeleton that I'm just going to throw in. When you stand, your vital capacity is better. There have been studies, granted, they've always been done with adults, and they're usually done with either brass or wind instrument players, that in standing, your vital capacity is better than it is in sitting or laying down. Does anybody know why you need a forced vital capacity and a strong one? Clear secretions, to cough, to talk. You need to be able to push air out and through to be able to talk. When you have the trunk extended, you can get more air in, you get an increased vital capacity, increased air exchange, but you can also get it out more, which is more of a passive thing. When Ginny talked about this morning, there aren't a whole lot of studies. This one, I think, is just so good because this child was 5 years old. She could not spontaneously evacuate. She was in pain. It was stressful. I wouldn't want to be her mom or her dad. The school therapist started her standing for 30 minutes a day, 5 days a week. She never had to be stimulated to be evacuated again. She was spontaneously evacuating. Her bowels. Those who work with children, people with cerebral palsy, how many small bowel obstructions do you go through? We go through adults, spinal cord, everybody. You need to keep the body going, and standing can help with digestion. And quality of life, especially for the wee ones, they can get close to people. They can touch people. They can hug their brothers and sisters. I'm still not sure. There's multiple studies in ages that show that people have improved self-esteem, improved sense of well-being, and improved participation. I'm not sure that the improved participation isn't due to the improved sense of well-being. They feel better about themselves. They're wanting to go out and try things more, and they're able to access their environment. It's not out of their reach. It's not away from them. There's not something between them and the other person. So for standing for little kids, because we want to start early intervention, we want to start as soon as possible. The guidelines say that you can start as early as 9 months corrected age. You can have your child in multiple positions, multisensory. You're getting proprioception, you're getting stretch, you're getting compression, and they can experience it. Proprioception is learned. Vision is learned. I worked for many years with a visually impaired population. Just because they can see it doesn't mean they know what it is. You need to teach it. Little rooms. Little rooms are all about reaching and exploring and feeling and learning what the environment is. You need to practice with your environment. You need to be successful to know how to do it, but you also need to fail so that you know when it doesn't quite work, how to fix it and how to do it in different places.